started like this. Okay.
So just to go through what we've discussed before, I'll go back to the beginning and what the problem is.
Yes,
Okay. So as you know, I'm holding this against me, the way things are inside. So this is the liver, or part of the liver, and then there are the two bile tubes coming out of the liver, going into the common bile duct, or the main bile tube. The gallbladder used to sit over there. Obviously, that's no longer there. Okay. So what we are dealing with is what we call a stricture or a narrowing in the bile tube in this area over here. Okay. And the problem is, if bile cannot flow through, it's like building a little wall across a stream. It'll start backing up. And so we know that the ducts sitting in this side of the liver are very dilated, okay, which tells us that the bile is not getting through on this side. But your liver is otherwise healthy, and there's enough liver doing the job that the liver needs to do, which is why you're not jaundice or anything. So everything is basically coming through the left side. So we know that they tried, obviously with a scope through the mouth, to try and get through this, through this little opening in the intestine. But as you know, Dr. Heimanot wasn't successful to get through there. And then also you had that little perforation over here, which is why you were in hospital after the scope.
Okay, it's not the stomach, it's on this
No,
side.
it's this part over here. It's where the scope was going in.
Oh,
Okay, so sometimes, he put that, what we call a spyglass camera in, which is a little camera, and that can sometimes cause a little tear in this duct over here and cause a little bit of leaking. It's not a big hole. It's just it's a tiny hole, and they say.
okay.
But anyway.
Because it was crazy. They were about to open me that time,
Yeah. So sometimes, but the problem is when you get leaking of pancreatic juice, it can cause a lot of pain and discomfort. Sometimes it can be a big hole, but it wasn't a big hole. You would have seen air and things like that in the rest of the abdomen on the CT. But again, I wasn't involved in that management, so I don't want to
you don't know what happened. Okay.
Yeah. So the question is still what to do about this. Okay. Now the problem is, we know that if the bile duct remains blocked for a long period of time, and when I say long period, this is not something that has to be done in a month or a week or even 6 months. We're talking years and years. The liver this part of the liver that's draining through this will start to shrink a little bit. And then there's the chance of getting infections, or possibly even getting abnormal cells developing in the bile tube if there's no flow of bile through that area, which is why we recommend doing something about this.
Okay.
So we then discussed what the options are. And the thing is, there's no right or wrong answer. There's just things that are possible. So the one possibility is, as we discussed before, is surgery, which is a big outing, because it essentially means that we need to remove all this. So removing this part of the liver, including the narrowed area. As I said, you've got enough liver, because it's still your liver's still functioning, and there's enough liver, and the liver regenerates, so it would replace what we remove.
All of it, even this side and that?
Yeah, so it doesn't look the same, but the number of cells that you need is determined by your body mass and a number of things, and the liver can regenerate, which is it's the only organ in the body that can do that. Okay, so, but as we discussed before, surgery it's a big operation. There's no doubt about it. It's quite a big cut under the ribs. The surgery is about 5 hours, and patients are usually in hospital for about a week afterwards. And then full recovery is usually after about, it's not that you won't be able to do anything, but full recovery back to normal would usually be about 2 to 3 months.
2 to 3 months.
Okay. So that's the one option.
Yeah.
Okay. Then the other option we talked about was instead of going this way, to try and come from the top. And that's the test that I was trying to explain on the phone to you. That's what the radiologists or the interventional radiologists do. So coming through the skin, they get into these big dilated ducts and they follow them down. Sorry, my pen's not working. They follow them down to the narrowing, okay? And once they get to the narrowing, they try and wiggle a little wire through that into the bile tube, which then runs down and into the stomach, okay? If they can get that wire through, you can then use that as it's like a railway track or like a railroad system. They can then push slightly bigger tubes through that over a period of time to stretch that up, okay? But you can't do it in one go. You can't take something that's really tight and just stretch it open. It'll not work because it'll just swell closed again. And B, this is something that's fairly hard, scarry, and it's better to actually dilate it slowly over a period of time. So the problem, or not the problem, the thing with this option is that it takes time. It's not just like one procedure and it's done. The first part will be to get the first tube in. And in order to, the tube, it's not a thick tube, okay, it's a tiny little tube, but it does hang out the skin. So there's no ways around that. There is a little tube outside the skin, which we connect to a small little bag. It's not a big bag.
Why do we have to have the bag?
Sorry?
Why do we have to have the bag?
Because there will be bile that wants to drain out and in. Okay, so the bag is to catch any bile. Initially, when we go in for the first time, we leave it on free drainage. Okay. If they are able to get through on the subsequent times when they actually dilate and stretch it up, if the thing's draining well, we can then sometimes leave it what we call capped, so without an actual bag. The tube is still on the skin because we need to use that to get access the next time they stretch it. But again, it depends on how well it goes with those other preceding things. And I can't predict that up front. As I said, the first thing they've got to see is if they can get through this way. Okay. The advantage to doing that is obviously you avoid a big operation. And, you know, it can be successful for sure, and it can sort out the problem like surgery. So that's sort of where we're sitting at the moment. I know your concern was working and what you would do with the bag and all that, and I get that. Yes, but as I said, I think realistically, if we went through the skin, the first procedure we need to admit you for and probably keep you in hospital for 2 or 3 days when they get the tube in. If they can get through, we would then usually wait about 2 to 3 weeks before they upsize it. And what we call upsizing it means to slowly stretch it. And that would usually mean coming back to the hospital because they have to do it in the x-ray department. Okay. The interventional radiologists do it, and they would then slowly upsize it. Depending on how that goes, that can be done as a day procedure or maybe an overnight admission just to make sure everything's okay. But as I said, it's a process as opposed to the surgery, which is sort of a one-time event. Does that make sense?
I understand though. But those procedures will, like, every time I have to go in, like, if example they can stretch it, you know, how many days do I have to stay, or is it an overnight thingy?
So I think if they get the first one in, then usually with the stretching it would usually be overnight. It depends how you tolerate it, because the thing is, you know, again, I don't know that until we're actually doing something. But obviously when we're stretching something that's narrow, it does cause a little bit of pain, and so we obviously need to manage that pain until it's controlled, and then we would look at sending you home. But an operation's painful too, you know, so that's the difficulty.
But that's a one-time thing, isn't it?
Yeah.
So it will not be definitive if how many months we will do that until we do it.
Until we know what the stricture's like and how stretchable it is. So we'll probably only know that after they've done one or two procedures to see how it's responding.
Understood. Right now, this one is less invasive, that tube, right? But it's not definitive.
Yeah, it's less invasive but more intensive in terms of commitment because of the number of procedures that's needed, if you know what I mean. So it's not like, you'd have to come and then come again. But I've had patients that have done well with dilatations for sure. But as I said, I've just got to be honest with you and say, these are the options. At the end of the day, if there was a right option and a wrong option, I'd be saying, well, we need to do this one for sure.
Okay.
But both of them are possibilities at the moment. There is the chance that if they can't get through for some reason, then the only option would be surgery. But we would know that after the first attempt if they can't get through. You know what I mean? So I think that's sort of the decision that we need to make. Okay.
The tube will be painful the whole time. It's
So
like there.
they give you sedation. They give you, as I said, I don't do the tube part. That's done by the interventional radiologists. They do these things all the time, and we have and they've got different medications they use. I don't do it, so I'm not sure what they use. But they obviously give stuff for pain and sedation and things like that to do it. Yeah.
Yes, but you said that it'll be here the whole time
Yeah,
while they're trying.
it'll be there all the time while we're stretching
trying
it
to stretch
because
it.
they don't want to, every time they go in, they don't want to prick you and start again. Once they've got access, they want to use that same access to slowly stretch it. So that little tube acts as the access that they can then just get through the next time easily.
Will it be painful the whole time? Like if it's 3 months we're talking about?
It shouldn't be painful the whole time. As I said, when they're stretching it, it could potentially be painful at the time they're stretching it and for a little while afterwards. But usually once you've stretched it, the pain settles down. It's like, like anything. It's the acute part of it is probably painful, but then it usually settles down. Yeah.
What are the success rate of this one?
So this, as I said, the success rate would be dependent on whether they can get through number one. Okay, so if they can't get through, the success rate is 0. Okay, but they don't know that until they've tried. Okay. I would say the success rate of if they can get through and then they can serially dilate it, the success rate can be high. It can be in the region of 75, 80, 90%. But again, it depends on how pliable or how easy it is to stretch that opened area.
No. It still depends on it, isn't it? But when it comes to I don't want to talk about if you cut it, then this will come back. The rest of it will come back.
If surgery, we physically take that away, and then the tissue, I mean, this is what the liver looks like. Okay, in reality, this is what the liver looks like. This has just got a piece that looks like this. Okay. So we will, because the bile tube is narrowed over here. So we need to take that portion off. And then once that is gone, this over 6 weeks will regrow. It doesn't look the same as this because it's just the functional mass or the actual functional tissue that is replaced.
Back.
Yeah,
Okay.
correct. But as I said, we know that even with this at the moment, your liver's still working well because you're not jaundiced, you're not, so yeah.
But it's not because I'm young right now that it will be like that.
It is, but
as I age, it will not be sufficient.
No, I don't. I think it would be fine. If you aged, it's not. Everybody ages, and even old livers regenerate. We wind up doing surgery on livers for liver tumors and all sorts of things, and sometimes our patients are 70, 75, and the liver still recovers.
Yeah. And the lifespan is not lessened or anything.
No. But obviously, any procedure, any surgery has risks with it. I'd be lying if I said it's 0, but that's the same. If you have your tonsils out, if you have appendix out, even though the risks are very, very small, they're never 0.
They're never 0.
Yeah. Okay. So I can see you need to think about it some more, and that's okay. Chat to your family, show them the video, see what they want. Okay.
And